My name is Kirsty Warden, and today my group and I will be discussing rotator cuff injuries among the older adult population for our research project. I'll be starting out by talking about the anatomy and physiology of the rotator cuff, following with the typical range of motion of the shoulder joint. We decided to choose the older adult population due to the statistical prevalence that age and rotator cuff tears go hand in hand. Rotator cuff tears are very common among the geriatric population. According to Gary Michael, who did a study on rotator cuff tears in the elderly population, he discovered that advanced age is related to having a higher incident rate of encountering rotator cuff tears. In adults around 80 years of age or older, they are 80% more prone to rotator cuff tears. The tears tend to be more massive tears, which are less receptive to being repaired by surgery. Then you can go to the next slide. In order to discuss the disordered shoulder, we will have to have a general understanding of the typical anatomy of the rotator cuff and how they move. I first want to clarify what the rotator cuff is. So a general definition of the rotator cuff provided by the Mayo Clinic states that the rotator cuff is a group of muscles and tendons surrounded by the shoulder joint, keeping the head of your humerus firmly within the shallow socket of the shoulder or glenoid cavity. The rotator cuff is very important in aiding you to perform daily and enjoyable activities such as reaching items on the top shelf, throwing a ball with your friends, or going swimming on a nice summer day. The rotator cuff is made up of four muscles: the subscapularis, supraspinatus, infraspinatus, and the teres minor. These muscles will arise from the scapula and insert into the humerus. During certain arm movements, the rotator cuff will contract and will prevent the head of the humerus from sliding, which allows for full range of motion. And then go to the next slide. The primary biomechanical role for the rotator cuff is to stabilize the glenohumeral joint by compressing the humeral head against the glenoid. And you can see this in this picture here, where the tendons are pulling the shoulder into the shoulder socket, or the humerus into the shoulder socket. Okay, next slide. Now moving on to discuss each individual muscle, what their important function is. One easy way to remember the muscles of the rotator cuff is to memorize the acronym SITS. The first muscle I'm going to talk about is the supraspinatus. The supraspinatus is located on the anterior aspect of the scalp, or the superior aspect of the scapula in the humerus. It originates in the medial 2/3 of the supraspinatus fossa of the scapula. It will pass over the glenohumeral joint and insert into the greater tuberosity of the humerus. This is the main muscle. The main muscle action of this muscle is abduction. It also is the most common muscle that is injured within the rotator cuff. Next will be the infraspinatus. The infraspinatus is located on the posterior aspect of the scapula. It originates in the infraspinosa fossa of the scapula and inserts into the greater tuberosity of the humerus, which is immediately below the supraspinatus. The main muscle actions of the infraspinatus is external rotation, horizontal abduction. It's the most powerful lateral rotator of the humerus, and the main muscle lets you rotate and extend your shoulder. The teres minor sits along the posterior part of the scapula inferiorly to the infraspinatus and superiorly to the teres minor. It originates in the lateral border of the scapula. It will insert into the greater tuberosity of the humerus below the infraspinatus tendon. This muscle action is external rotation. It is the smallest rotator cuff, and its main job is to assist with rotation of the arm away from the body. Next, I wanted to be talking about the subscapularis. The subscapularis is a large triangular shape and is the largest and strongest muscle within the rotator cuff. Its origin is the anterior surface of the subscapular fossa of the scapula, and it inserts into the tubercle of the humerus. The main muscle actions for the subscapularis is internal rotation, abduction, and extension. It prevents anterior dislocation of the humerus during abduction and medially rotates the humerus. It also holds your upper arm bone into your shoulder blade and helps you rotate your arm, holding it straight out and lowering it. Since the rotator cuff muscles aren't very large, in order for them to work properly, they have to have excess muscular strength and endurance. Lastly, I'll be talking about the typical range of motion of the shoulder joint. It's important to obtain good range of motion in your shoulder joint because if your range of motion isn't up to the recommended degrees, it could lead to injury and making performing activities of daily living very difficult. Determining the specific range of motion for the glenohumeral joint is sometimes very difficult because the shoulder girdle assists in the movement. In order to see the shoulder's range of motion, there's testing that can be performed, and it will be measured by the use of a goniometer pictured to the right. There will be an examiner performing the testing. That it will be tested in many different directions, and multiple tests are to be performed Because if one specific direction is painful or lacking mobility, it could signify a tear or an impingement in the shoulder. The first range of motion I wanted to go over was forward flexion, and then you just go like this. Cool. You'll start with having the patient with their arms by their sides, and you'll ask them to raise their arms fully straight up in front of them as high as they can go with their thumbs pointing upwards. This test will be moving the humerus straight anteriorly. The typical degrees for forward flexion if the shoulder girdle is prevented from moving would be 90 to 100. The typical range of motion for a degree if the shoulder is free to move would be 140 to 150. Here's backward extension. I kind of figure out how I'm going to introduce the video, but okay. You'll have the patient start with their arms by their side with the palm of their hands facing forward and the arms fully extended, pushing them backwards. You'll be moving the humerus straight posteriorly during this test. The typical degrees for backward extension would be around 40 to 60 degrees. Next would be abduction. You'll start with their arms by their sides, ask them to raise their arms laterally until they can have their hands above their head. The examiner will support the scapula during this test, making this a passive test. This movement will be an upward lateral movement of the humerus out to the side. And the typical degrees for the abduction, if the shoulder girdle is prevented from moving, would be 90 to 100. If the shoulder is free to move, it will be 170 to 180. Next is cross-body abduction. You'll have the patient flex their upper extremity forward to 90 degrees. From this position, you'll ask the patient to abduct their shoulder by moving the arm horizontally all the way to the other side. The typical average for degrees for cross-body abduction would be around 116. Next, I'll be talking about external rotation. Here's a video. You'll ask the patient to flex the elbow at 90 degrees with the arm attached to the trunk and the palm supinated. Then have the patient externally rotate the shoulder by bringing the forearms laterally. The typical degrees for external rotation would be around 70 to 90. Lastly, I'll be talking about the high posterior reach with the thumb. The back of the hand will be placed on the lower back, and the patient is asked to reach as high as they can along the spine to the highest level that they can reach, and it will be marked. So here's a video of that. The typical range of motion is marked on the picture to the right, and the typical thing would be between the vertebrae 4 and the thoracic vertebrae 8, as marked by the red lines. Next would be the liftoff test. So these tests that I'm about to go over is to see if there's a specific muscle that is lacking, and it tests each specific muscle of the rotator cuff. So the first specific test I have is the liftoff test, and it is to test the subscapularis. Here's a video of the liftoff test. This would be a negative test. The reason this is a good test for the subscapularis is because when your hand is on your lower back, in this position, it puts the greatest amount of stress on the muscle. The patient will be touching their lower back with their arm fully extended and internally rotated. The test will be judged positive if the patient is unable to lift his or her hand off of the back, and they can also press up against it to see if they need excess strength in it. Next, I'll be talking about the empty can test. This is a good indicator for the supraspinatus. And here is a video of it. During this test, you'll have the patient raise their arms at 90 degrees in the subscapular plane and tell them to internally rotate their thumbs facing the ground. They'll be acting like they're pouring out a can. The examiner will apply downward pressure to the patient's arm, and they will need to resist pressure. This will be considered a passive test. This test is also positive if there is weakness or resistance within the arms at 90 degrees of abduction. Lastly is a hornblower sign test. This indicates the teres minor and infraspinatus. And then he'll do this. It's probably my watch. It's my watch. And play it. You'll have the patient sit down and have the patient's arm at 90 degrees of abduction in the subscapular plane with the elbows flexed at 90 degrees. The examiner will have the patient's arm supported at the elbow and have their hand on the other patient's hand. The patient then attempts to externally rotate the forearm against the resistance of the examiner's hand. If the patient cannot externally rotate, they assume the position's characteristic a positive of the hornblower sign test. As previously mentioned, the rotator cuff muscles are for performing overhead activities such as throwing, swimming, combing your hair, or reaching things on the top shelf. If these activities are performed with poor technique, it will lead to failure of the rotator cuff stabilizing your humerus. Now that the normal anatomy and physiology of the shoulder joint has been established, Caitlin Springer will discuss the mechanisms of injury due to degenerative tears of the rotator cuff that are common among older adults. Okay. It's in 19, so we're good. If I let the videos play, I'll be fine.
Okay, my name is Caitlin Springer, and as Kirsty mentioned, I will be discussing degenerative tears of the rotator cuff in the older adult population. Not only are tears of this nature important to study due to their prevalence and proportional increase with age, as Kirsty formerly established, but they also have clinical relevance because muscle degeneration is associated with decreased clinical outcomes and slower tendon healing. Degenerative tears may or may not be symptomatic or pain-inducing, but will worsen over time without intervention. When discussing the etiology of the degeneration of the rotator cuff, it is helpful to explore the changes that occur over time within its muscles and tendons in order to create an overall musculoskeletal environment that is prone to deterioration. Although repetitive overhead motions can speed the degenerative process, there is not one singular movement that causes degenerative rotator cuff tears. Rather, it is a sum of tissue changes that occur with aging alongside cumulative wear and tear. As individuals age into later adulthood, the frequency and intensity of physical activity tends to decrease. So as the muscles of the rotator cuff are used less, they decrease in size and strength in a process called disuse atrophy. Mechanical unloading refers to a decrease or lack of power and force expended by the muscles due to low levels of movement against resistance. So that could mean not moving very much just in normal motions against gravity, or not moving against external resistance, such as a weight or carrying an object. And mechanical unloading is often associated with prolonged inactivity, such as bed rest, and it can further contribute to disuse atrophy. Within the muscles of the rotator cuff, as the muscles become smaller, thinner, and weaker throughout degeneration, the muscles begin to retract and fat begins to deposit abnormally in the shoulder. So this image is depicting 3 stages of retraction of the supraspinatus muscle. And just as the motion of shoulder retraction refers to the scapula moving medially toward the spinal column, pathological retraction of the rotator cuff involves the muscles and tendons shifting away from their normal insertion and moving towards midline. So in this image, the supraspinatus is gradually slipping from its normal insertion on the greater tubercle of the humerus and moving along the spine of the scapula towards its medial border. Not only does the muscle shrink and change location during degeneration, but the muscle tissue that does remain often changes in its composition as excessive fat begins to deposit in a process called fatty infiltration. As the muscles atrophy, they also undergo remodeling at the muscle fiber and tissue levels. In the space where muscle used to reside in the rotator cuff, fat begins to accumulate. Adipose tissue is not contractile like muscle tissue is, so it disrupts the movement efficiency and force capacity of the rotator cuff. This MRI shown is one of the rotator cuff from the sagittal plane view, as if you had divided the body into left and right portions and you removed the arm out of the way so that you could look deep into the shoulder girdle as if you were standing perpendicular next to the person. The white arch shown on the right of the image is the posterior body surface and the skin covering the shoulder. And then the Y shape in the center is the scapula, and with the right branch being the bisected spine of the scapula, and the dark gray surrounding that is the muscles of the rotator cuff. And then any other light gray or white circles or streaks are showing fat deposits within the muscle. So in Fuchs' stage 1, which is on the leftmost image, there is minimal or no fat deposited. In stage 2, in the middle, there are a moderate amount of fatty streaks within the muscle, but at this stage, there's still proportionally more muscle than fat. But then in Fuchs stage 3, all the way on the right, there is a severe fatty infiltration of the rotator cuff, and there's either equal amounts of muscle and fat or greater amount of fat than there is muscle. The tendons of the rotator cuff also undergo degeneration. In early degeneration, the tendons change at the minuscule microstructure level with tiny tears, but these add up into noticeable deficiencies in the whole tendon structure and function as it becomes less able to withstand stress. Ultimately, a rotator cuff tendon may tear completely and fail altogether, so it becomes unable to perform the mechanical role in transmitting the force produced by the rotator cuff muscles to the humerus bone. Depending on the tendon involved, moving the arm in certain directions and dynamically stabilizing shoulder movements will be reduced or prohibited. In response to the chronic degeneration of the shoulder, inflammatory cells of the immune system will migrate in an attempt to facilitate healing, and then they will accumulate within the rotator cuff tendons. Some authorities believe that these residing inflammatory cells send signals that modulate and control rotator cuff degeneration in a type of autoimmune response. Degenerative tears can occur in any of the 4 muscles of the rotator cuff, but they frequently initiate in a specific region known as the rotator crescent. This crescent that is shown on the picture on the left is a half-moon shaped portion of the rotator cuff between the biceps tendon and the inferior border of the infraspinatus tendon. And this crescent is bordered and outlined by the rotator cable, which is shown with the dotted black line, which is a thick bundle of fibrous tissue at the intersection of the glenohumeral and coracohumeral ligaments. This arched cable is structured kind of like a suspension bridge that protects the more delicate crescent from stress in the case of healthy shoulders. However, this area does not have a good blood supply and therefore does not heal well and thins progressively with increasing age. This picture shown is a photograph of a cadaver with the rotator cuff muscles lifted off of the head of the humerus to show the common location where degenerative tears typically initiate. The junction between the insertions of the posterior portion of the supraspinatus and anterior portion of the infraspinatus tendons, approximately 15 to 16 millimeters posterior to the biceps tendon, is particularly vulnerable, represented by the star shape in the picture, and where tears usually begin. Because so many structural and functional changes are involved in the degenerative tears, and these changes occur cumulatively and progressively worsen over time, the rotator cuff is not likely to regenerate. This is not to say that treatment interventions are not worthwhile, but rather that full restoration of the rotator cuff's typical functionality and mobility should not be expected when the tear is degenerative in nature. After a tear is initiated, it will propagate and spread out in width and depth from that location. If the degeneration becomes advanced and the tear spreads and surpasses a critical size threshold, the rotator cuff will no longer be able to stabilize the position of the humeral head in its healthy location, and it will begin to migrate proximally. This means that the head of the humerus will move medially and crush inward on the glenoid cavity, which can dramatically disrupt the kinematics of the shoulder. Each individual muscle of the rotator cuff plays an important role in the stabilization and movements of the glenohumeral joint, but they also act in synergy with the deltoid and other muscles to balance the forces as the shoulder moves through its range of motion. Therefore, damage in one rotator cuff muscle will also impair its ability to contribute to its muscular partnership, which then impairs movement and stability beyond simply its own independent roles. This illustration depicts a full thickness tear in the most commonly torn rotator cuff muscle, which is the supraspinatus. It is also showing a good representation of the important rotator cuff cable that we talked about underneath. Degenerative tears that progress to this stage, the full thickness, are considered to be massive injuries and likely cause noticeable changes that can be detected by abnormal results in range of motion tests like those Kirsty outlined, as well as in deficits in functional testing. And these are my references that I utilize for both the informational content and images in this section. Next, Mary will be further describing a common type of rotator cuff tendon injury, which is impingement syndrome.
As Caitlin mentioned, my name is Mary Walker, and I will be covering impingement syndrome today for my portion of this presentation. Covering impingement syndrome is relevant for our presentation pertaining to older adults because the incidence of shoulder impingement syndrome increases with age. Statistically speaking, peak incidence of shoulder impingement syndrome is within the 6th decade of life. To provide a good foundation for understanding the technical details surrounding shoulder impingement syndrome, it is important to first understand what shoulder impingement syndrome looks like from a general standpoint. The signs and symptoms of shoulder impingement syndrome commonly seen are pain with lifting arm, pain with lying on the affected side, pain located over lateral acromion with radiation to lateral mid-humerus, weakness during abduction, and also weakness during external rotation on the affected side, and tenderness with palpation over coracoid process of the affected arm. I find it important to mention that often onset of shoulder impingement syndrome is a gradual occurrence. So individuals suffering from this aren't able to identify a specific event that they can trace back to where the pain started. In terms of a timeline, this pain can develop over weeks or months. There are 4 common types of shoulder impingement syndrome. Those types are anterior acromial impingement, posterior superior glenoid rim impingement, subcorporeal impingement, and also suprascapular nerve impingement. And the potential cause of each type differs. And we're actually going to cover those really quickly. Beginning with anterior subacromial impingement. And this is whenever the tissues filling the subacromial space are trapped between the humeral head and the coracoid arch. The soft tissues are the subacromial bursa, supraspinatus tendon, and also the biceps tendon. Moving along to the posterior glenoid rim impingement, this is potentially caused by the inner fibers of the rotator cuff and fibers of the posterior superior labrum between the greater tuberosity and the posterior superior glenoid being compressed. The subcoracoid impingement is potentially caused by a posterior rise of the humerus in a plane of 30 degrees combined with internal rotation. And then there's also suprascapular nerve impingement, which is potentially caused by intrusion of the suprascapular nerve. You'll notice within this presentation that the anterior subacromial impingement is bolded. That is because that is by far the most common type of impingement seen. And so with that being said, for the remainder of my portion of this presentation, I will be focusing solely on subacromial impingement. Before jumping into specifics, I did want to appreciate how far we have come in terms of knowledge concerning impingement syndrome. In 1934, a man with the last name of Codman determined that he thought rotator cuff lesions were caused by rubbing of the humeral head in the acromion. And then years later, in 1972, Charles Neer coined the term of impingement and became the first to establish many of the specifics surrounding subacromial impingement syndrome that we still utilize today. It is important to mention that subacromial impingement syndrome has 2 different forms. So we have primary and secondary forms. The primary form of impingement is when the impingement is caused by changes to the structure that mechanically narrow the subacromial space. The primary form of impingement can be from bony narrowing on the cranial side, which is also called outlet impingement, bony malposition after a fracture of the greater tubercle, or an increase in the volume of the subacromial soft tissue on the caudal side, which is also known as non-outlet impingement. The other form, which I've mentioned, is secondary impingement, results from the humeral head being uncentered, which leads to abnormal placement of the humeral head, which eventually causes entrapment of soft tissues, which leads to the pain. There are two different mechanisms proposed for the cause of subacromial impingement syndrome. As seen here, those are extrinsic and intrinsic mechanisms. There is the extrinsic mechanism that suggests the impingement causes damage to the tendons, and then there's intrinsic mechanisms which suggest the damage to the rotator cuff tendons leads to impingement. Most commonly seen is external impingement, and external impingement is associated with inflammation and irritation of the structure within the subacromial space. So in attempt to better understand external impingement, it is important to be able to associate the space with the anatomical features surrounding it. So you can use this picture to help you see that. But the acromion and the coraacromial ligament are the anterior border. The superior border is the acromioclavicular joint, which is also known as the AC joint, and the inferior border is the humeral head. Interestingly, the shape of the acromion is believed to potentially play a part in the genesis of external impingement syndrome. Pictured here to the left, you can see the subacromial space and the coracoacromial ligament. And to the right, you can see the supraspinatus tendon with the dash arrow, and then with the asterisk, you can see the acromion. Forward flexion, internal rotation, shoulder abduction, and any normal shoulder girdle movement requires narrowing of the subacromial space. And this space is typically 1.0 to 1.5 centimeters in width, and it narrows whenever the humeral head migrates superiorly. So when the humeral head rises in that way, it approaches the anteroinferior edge of the acromion. And if one is suffering from external subacromial shoulder impingement syndrome, the pain that they are noticing is due to the humeral head applying a force that compresses to the rotator cuff, the subacromial bursa, or both. It should also be noted that repetitive compression of the rotator cuff tendons are known to contribute to the narrowing of the subacromial space. And with this being said, it is currently not known if the damaged tendons cause impingement or if a smaller acromial space causes the tendon inflammation. The biomechanic mechanisms that explains extrinsic subacromial impingement syndrome is simply based upon the narrowing of the space leading to the rotator cuff tendon compression. So the compression can occur from the humeral head moving superiorly or the acromion moving inferiorly. And because of this, the rotator cuff muscle performance suffers. So as seen in this photo, the arrows show that due to contact between the humeral head and the acromion, there is impingement of the soft tissues, which causes pain. I wanted to discuss some of the predisposing factors to subacromial impingement syndrome. You can see some predisposing factors listed here, beginning with an off shape of the acromion, an off orientation of the acromion, presence of osteophytes at the AC joint, also known as the acromioclavicular joint, and ossification of the coracoacromial ligament, and also presence of os acromial. As an example, this picture indicates a clavicle. It includes a clavicle with the open arrow and a low-lying acromion. So it's an off, the acromion's in a bad placement. You can see that with the solid arrow. An acromion is an acromion that's low-lying would predispose someone to subacromial impingement syndrome due to a lessening of space available for the subacromial anatomical features to comfortably reside. There are stages associated with subacromial impingement syndrome, and those stages were discovered and called out by Charles Neer, who we mentioned earlier in this presentation. In the first stage, stage 1 impingement syndrome is resulting from edema, hemorrhage, or both, and this is often seen with overuse. Stage 2 is characterized by greater fibrosis and irreversible tendon changes, and stage 3 is associated with a rupture or tear of the tendon that may result from longstanding fibrosis. I also wanted to mention the tests that are utilized to determine if an individual has subacromial impingement syndrome. So there is the Hawkins test, which runs positive if pain arises when the patient completes max internal rotation at 90 degrees with elbow flexion. So this test highlights what occurs when the subacromial space between the greater tubercle and the coraacromial ligament is narrowed. There's also the near sign test, where one hand fixes on the scapula and the other rises and internally rotates the arm. This causes the greater tubercle and the roof of the shoulder joint to make contact. Thirdly, there is the Job test, which is where the individual will raise their arms in a frame of 90 degrees of abduction with 45 degrees of flexion while internally rotating. The individual will try to elevate his or her arms further against the resistance. Lastly, there is the painful arch test. This test will highlight any pain during abduction with an extended elbow in a scapular plane between 60 degrees and 120 degrees. And here are my references that I used during my portion of the presentation. And next, Dawson will cover the conclusion and novel research on shoulder joint injuries.
Hello, my name is Dawson Russell. Before I get into my part of the presentation, I'd like to provide an overview of what my fellow group members have already stated. Kirsty, she started off by talking about the anatomy and physiology of the rotator cuff. And second, Kaylin, she got into the degenerative injuries of the rotator cuff. And then third, Mary, she covered the impingement syndrome. And then before I get into my part, this is the shoulder anatomy. What I will be focusing on mainly is the shoulder joint. It is comprised of the collarbone, shoulder blade, and the upper arm bone. The other shoulder joint injuries that I'll be focusing on first is the shoulder instability. It's caused when the head of the upper arm bone is forced out of the shoulder socket. It could be partially or fully forced out. This can happen from overuse or sudden injury. Also, once it has been dislocated, there's a future chance of re-injuring it because it is vulnerable and it will dislocate again in the future. Next is the frozen shoulder, also known as adhesive capsulitis. It has 3 different stages. The first stage is freezing, which is will slowly have more pain and stiffness in the shoulder. It lasts usually from 6 weeks to 9 months. You will lose your full range of motion mostly in this stage. Stage 2 is the frozen stage. Symptoms improve, but the stiffness worsens and it lasts 4 to 6 months. Usually makes your daily activities difficult to do. And then stage 3 is thawing, which your range of motion improves slowly over time, but it will take usually up to 6 months to 2 years. Frozen shoulder affects people in the ages of 40 to 60 and occurs in women more than men. And then next is arthritis. Arthritis is the inflammation of one or more of your joints. It causes pain and stiffness. There's nothing you can really do to cure arthritis. You can only manage the pain by staying active and taking over-the-counter medications. 5 major types that affect the shoulder are the first one is osteoarthritis, or the wear and tear arthritis. It usually scrapes the cartilage over your bones. And then next is the rheumatoid arthritis, which is the chronic disease. It affects 2 joints at a time, and it can affect the opposite side of where you're having your pain at as well. Post-traumatic arthritis, it usually occurs after an injury. And then next is the rotator cuff arthropathy. The arthritis develops after a long-standing or a large tear in your rotator cuff. This damages the surfaces of your bones and could lead to not being able to move your arm from your side. And then lastly, avascular necrosis. It's a painful condition when the blood supply to the head of the humerus is disrupted. Thus, AVN leads to damage of the shoulder joint, and then this leads to the destruction of the whole shoulder itself and leaving dead bone behind. Fractures, dislocations, and separations. First, fractures, it is a break in bone. It happens usually in sports injuries, but can happen in car accidents as well. Other causes that are not injury related is low bone density and osteoporosis. Overuse can also cause stress fractures. And the next, dislocations. Older adults are usually the ones that are affected most by dislocations, especially women, because they're more likely to fall. A dislocation is when the ball pops out of the shoulder socket and could be partially or fully dislocated. And then next is separations. This is not a true shoulder joint injury because it involves the AC joint. The AC joint is where the clavicle meets the highest point of the shoulder blade. Most common injury of separations is falls. This injures the ligaments around the AC joint. If severe enough, it could cause separation from the collarbone and the shoulder blade. This ranges from mild, which is a sprain, to a full, which is a separation. And then lastly, for these injuries, surgery or non-surgical procedures will be required depending on the size of tear or the injury that you have. It could be differentiated between dislocated, fractured, and separated. Next, I'll get into present and future implications of degenerative and impingement injuries, how they could affect your daily activities. If left untreated, it can completely tear a tendon and a surgery will be required. Also, it could affect daily activities by your range of motion of the shoulder will be inhibited. Overhead lifting and reaching will be affected. Shoulder strength will be weakened. Simple tasks such as combing your hair and going to the fridge and opening it up, lifting into cabinets will be affected. Especially lifting your arms straight out would be painful. These tasks are not just easy anymore. They could further your healing. It could damage the joint if you continue to repeatedly do them. Risk factors leading to degenerative impingement injuries. They're mostly caused by wear and tear of daily living. Aging is another big thing, and people over 40 have increased risk over time. Repetitive lifting and overhead activities increase these risks. Sports such as baseball and tennis, if you play them, have the most shoulder joint injuries in their respective sports. Future effects over time of these injuries, repetitive stress of the shoulder motions stress the rotator cuff. Also, a lack of blood supply. This is usually because of age, because this is the body's natural ability to repair damage. Bone spurs will begin to set in. With bone spur is just a bone overgrowth that develops on the underside of the shoulder blade, and then when we lift our arms, the spurs rub the rotator cuff tendon, which leads to shoulder impingement. And then future or environmental and other factors affecting the rotator cuff are you could re-tear them after you have had surgery on them. Also, if you have diabetes, it increases the risk even more to re-tear it or tear it. It also increases the size of the tear. And then you will have reduced tendon length from surgery. Body mass index plays a big role. Dyslipidemia, which is fatty lipids that are excessive in your bloodstream. And then occupation ratio and a fatty infiltration of your infraspinatus are significant risk factors. Also, vascular changes, your age, sex, genetic, tensile forces, and then other environmental factors, your sports that you play, your job, smoking, and medical comorbidities play a big role. Injury prevention and training. The best type of training that you can do is eccentric training. This consists of the contraction and controlling the load while the muscle and the tendon are stretching and they continue to stretch. This treatment is widely advocated as a treatment for tendinopathy. Eccentric exercises expose the tendon to greater loads rather than concentric training does. These are just the best exercises that you can do for the tendon itself. Your shoulder muscles that you need to be targeting while training are the deltoids, traps, rhomboids, teres muscles, supraspinatus, infraspinatus, subscapularis, biceps, and triceps. The types of stretches that you will need to be doing is the crossover arm stretch, passive internal rotation, passive external rotation, the sleeper stretch, the standing row with band, and the pendulum. The range of motion that you would want to strive for is 180 degrees for the flexion and abduction and 90 degrees for external rotation. And then lastly, a new approach that I could find to shoulder joint research was the ADCAB, which is the new approach to shoulder pain. It's the most recent study that I could find in the field of shoulder joint research. It is a study of gene expression and molecular pathways in painful conditions of the shoulder. The study hopes to improve the quality of life and treatment and outcomes for people with shoulder injuries. The doctors in the study use adhesive capsulitis biomarkers to study gene expression and alterations. And then also the doctor uses biobanking, which is a large collection of tissue samples to answer the questions for the cause of their skeletal conditions. And then lastly, here's my references that I used to find the research. And that's it. But I want to real quick at the start, so.
Oh, good. We
Just
were
15.
at 3943 total.
I'm gonna add some pictures that I need to talk about as well.
Yes, I can tell each of you your times as well.
Whenever I practiced mine at home, I was always over 10 minutes.
That's
and
how
I
Right,
I
me
was going
too.
so
Yeah.
slow. I was
And
like,
so here I tried to go fast, and then
I forgot to end
that's
that.
what I did. And then I got to 19 and I was originally getting like 11 something.
yeah.